Hi everyone, I'm on day 2 of ACR and I want to report back on my second session of the day. So I just attended a session that was all about imaging and AxSpA, and here are my key takeaways. So the first thing is that Pediatrics does not have good diagnosis criteria for AxSpA or treatment guidelines beyond TNFs. And they have to apply adult findings to their patients and adjust for the symptoms that they're seeing in peds versus adults. When you think about that, as adults, we have so many different types of biologics at this point, and the kids still only have TNFs. But they're starting to progress patients from a TNF inhibitor to an interleukin-17 inhibitor like Cosentyx, skipping over methotrexate and adding more NSAIDs because NSAIDs aren't going to stop the disease progression, and methotrexate doesn't really have any evidence that it's going to work for AxSpA. So that's really cool that they're not putting kids through methotrexate and that they are forming their own conclusions on Cosentyx because it made FDA approval, but they haven't adjusted the treatment guidelines. And the next thing that we learned was some clinicians are starting to use imaging to help present the findings to the patients, which gives the patients a visual to go with their experience and helps them understand a little bit better because they can actually see what's happening, and a lot of what we usually have is invisible. So that's a really cool progression. And they're looking at using MRIs more for diagnostic abilities in AxSpA, because it actually gives you a more definitive diagnosis than any of the lab markers that we are used to, or x-rays, because it might not present on an x-ray yet. And so if they can see lesions on the MRIs, that's a really good indicator of the disease, and it can actually help predict that you might progress to radiographic findings. And so they can kind of use that original inflammation on the MRI to start diagnosing you, treating you, and hopefully slow the disease progression because you're getting a treatment faster. The catch is that the MRIs are really hard to read. They say you have to be like a detective to appropriately review the MRIs and make a good conclusion, which leads me into the next one, which is all about how AxSpA can mimic other conditions on MRI and X-ray. And so again, you had to be a detective to make sure that you're finding the right thing when you're looking at it and that you're taking the whole picture into account, because sometimes AxSpA could look like sacral inflammation, which is a key thing you look for in AxSpA. But if you're pregnant, you're also going to have sacral inflammation. So you want to take that into account and not jump to a conclusion that they have AxSpA if they're pregnant. They could, but they might not. So just something to look out for clinicians. But overall, it's pretty cool that they're starting to use MRIs instead of just x-rays and waiting for the actual damage to occur, to actually just be able to watch for the inflammation and predict from there. It's kind of amazing. That's all I have for this one, and I'll see you on the next one. Thanks.